Good afternoon, everyone, and very warm welcome to all of you. I'm Shifa Sheikh from Docplexus. As we all know, Docplexus is India's largest and most trusted online community of verified doctors dedicated to continuous medical education, peer to peer learning, and evidence based clinical discussions. Over the years, we have connected with thousands of clinicians through scientific webinars, case based learning initiatives, and expert led masterclasses empowering doctors to deliver better patient care. I'm delighted to welcome you all to today's webinar on very interesting and unique topic, risk communication and promoting health, which plays a crucial role in public health practice, patient education, and effective health delivery. In today's rapidly evolving healthcare environment, clear communication of risks and proper health promotion strategies are essential for improving patient outcomes as well as community health awareness. For this very important and highly interested topic, it's my pleasure to introduce our esteemed speaker for today's event, Dr. Amitav Banerjee. Dr. Banerjee is an accomplished medical professional with qualification MBBS, MD in preventive and social medicines and postdoctoral training in clinical epidemiology. He is currently serving as professor in Department of Community Medicines at Dr. D.Y. Patil Medical College, Pune. He served in the Indian Armed Forces more than 25 years, from 1978 to 2025, and has vast experience in public health, epidemiology, and medical education. Dr. Banerjee has published over 100 of research papers in national and international journals and has led several funded research projects and has delivered numerous key lectures at prestigious national and international conferences. We are truly honored to have him with us today and we look forward to learning from his valuable experience and knowledge. So, without further delay, I would like to hand over the sessions to Dr. Banerjee. Over to you, sir.
Thank you, Sifa. And it is always a pleasure to come on this Docplexus platform and share my views with my esteemed colleagues. So today I'll be trying to bridge the gap between epidemiology and clinical medicine. This has been my experience for years of decades of teaching epidemiology, public health, that once you clear the exams in epidemiology and most of you go to clinical medicine, you tend to forget very fast the principles. And it is again my experience that clinicians have a bigger impact on the people, on the patients, on the community. And if in their day to day practice, if they apply the principles of epidemiology while interacting with the individual patients, the doctor patient relationship will be better and patient communication would be evidence based and the credibility of the doctors will be better. So I will be discussing this topic under the following heads, that how do you go about promoting health in clinical practice, health promotion. And most patients will come with the question when they fall sick, could it have been prevented? For future episodes or for other members in the family. And here comes the your skill in how to communicate the risk. What are the risks for a particular disease so that they avoid it in future or they avoid it in the family, and how clinicians can promote health in this way. And then there are certain universal uh, health messages like smoking, alcohol, exercise and diet, which is becoming more important with the sedentary lifestyle, and sexual behavior, safe sex. So these are the topics, and we come first to health promotion. Health promotion is a lifestyle promotion which can prevent a number of diseases, and it is a major focus, as we all know, and it is becoming increasingly important in clinical medicine because, as I said, patients are having more and more sedentary lifestyle, overeating, dietary indiscretions, and physicians can play a vital role when they come in contact with the patients. And they can also contribute to secondary prevention, that is early diagnosis and treatment. Like you take a blood pressure reading, you may detect high blood pressure or hypertension earlier before it can proceed to complications. Similar routine urine examination or a blood glucose level, you may detect impaired glucose tolerance. And of course, in tertiary prevention also, even after say an episode of a myocardial infarction or a cardiac event, the rehabilitation may involve behavioral changes like tobacco cessation and other advice. So all these come, there is an interface with your preventive medicine and levels of prevention. If you can recall your preventive medicine days, primary prevention means health promotion. Sometimes there is a specific protection. Maybe you may recommend some vaccines for a particular disease. Then secondary prevention is early diagnosis and treatment. And tertiary prevention is rehabilitation. After a cardiac event, you try to address those risk factors which had led to the event. So it's so seamless if you see your epidemiology and clinical medicine is clinical epidemiology, which is seamless. But unfortunately, all these decades we have compartmentalized it. So in practice, the clinicians can deliver more of preventive medicine because of the closer contact with patients. So patients may always ask this question, why me? Uh, I'm just giving an example. A patient comes with a say fracture, knocked down with a speeding vehicle. Unfortunately, it is very common in India. Daily, we have got more than 400 to 500 deaths from road traffic accidents daily in India. So immediate cause may be reckless driving, but there are other causes which the clinicians, if he is got some social responsibility, he or she can pursue those things. Immediately, of course, is treating the patients and then exploring the other web of causation. There is no single factor for the fracture. So decision to cycle on that road on that day. It's a unsafe road. There are no cycling tracks. Lack of safe cycling tracks. So these are the environmental changes which one can promote. Poor implementation of traffic rules and overspeeding. So as a physician, one can they are respected in society. One can write columns. One can give health awareness to the policymakers, to the traffic police, and go beyond their clinical practice to bring down the road traffic accidents. So immediate cause is one thing, but you have to see the larger social environment. So agent host environment. The host factors are the decision to cycle on a busy highway. So that can be educated. Then of course wearing of helmets and for even for cyclists. So these are to think beyond and to reach out to the community for remedial measures. So these are complex web, like there may be some other conditions, there may be social factors, like your peer pressure may lead to tobacco misuse, alcohol misuse, genetic factors. So identifying in clinical practice and behavioral factors and so from the epidemiology of public from the population, you collect the evidence and one can apply it to the patient in front of you, individual patient. What particular evidence-based risk factors applies in your individual patient. So you have to see the social factors. So you have to keep on practicing this so that it becomes a second habit, and this is how you get back the art of medicine. Instead of just blanket guidelines, each patient will be unique and each condition you have to search for either in these domains. So what are the to go forward? What are the clinicians' role in preventive medicine? So with these in identifying this will help you advise your patients to avoid future problems by providing general advice about say lifestyle, identifying specific risk behaviors and helping patients to avoid them, ensuring specific preventive measures. Example, vaccination if indicated. If the person is at high risk, depending on the disease, depending on the vaccine, how effective is the vaccine? It shouldn't be blind also. What are the side effects of the vaccine? And with the patient's informed consent, and how serious is the disease, how vulnerable is the patient. If the patient is, say, very frail, bedridden, definitely the patient may require, say, protection from seasonal influenzas or pneumococcal. But if the patient is hale and hearty, walking around, so you have to see, because there may be some adverse effects of vaccine, or and the patient may be at lesser risk. So you have to take an individual call in consultation with the patient. So vaccination is specific protection. Identifying early disease and managing that we have already said, say blood pressure monitoring, counseling patients about possible causes like association of obesity with high blood pressure and impaired glucose tolerance. Obesity is a looming problem. It is fast assuming dimensions of a pandemic, and there is a market forces are also coming in with fast food causing the obesity, and then of course the sale of weight reduction drugs is projected to be $1 billion business, if not trillion. So in this environment, it is the clinician who have to about obesity and how it is associated with blood pressure and impaired glucose tolerance, diabetes. And of course, one has to caution the patient also, because the high pressure promotion of anti-obesity drugs may make the patients complacent. That there is a treatment, there is a pharmacological therapy for obesity. So that should be stressed, that that should be the last resort. And that self-medication and should be avoided with anti-obesity drugs. They have got serious side effects, as you most may be aware. As it is being rolled out, the side effects are coming to light. So the clinician is in the best position to advise the patient and inform them. Advising patient how to reduce poor outcomes by weight loss, exercise, smoking. These are always across the board for most non-communicable disease, and also for communicable disease. Because if you are a heavy smoker, you are more uh, vulnerable to respiratory infections, poor lung function. And of course, for non-communicable disease, all these are very important risk factors. Identifying other risk factors, say contact tracing for infectious disease, or children of women with breast cancer, so genetic determinant, BRCA2. So this can help in prevention of identify a particular gene, and which can help in more regular breast screening, or in extreme cases may advise mastectomy. But of course that extreme depends on the individual choice. Health activism for policies which promote health, as we have seen for road traffic accidents. uh, the clinician can have a better influence on the policymakers. And these are of course general guidelines: avoid tobacco, healthy diet, high in fruits, vegetables. This are becoming more and more important with rising marketing of ultra processed foods. Low in salt, sugar, red meat, and saturated fat. Avoid excessive alcohol. Increase physical activity. Moving around, using the stairs instead of the lift. It can be built in. Getting up after at regular intervals. Those who are in sedentary lifestyle, most of the IT professionals are sitting in front of computers throughout the day. So you can advise them, after every hour they can take some break to walk around 10 minutes, then come back. So that can go a long way in controlling the overweight and obesity. And safe sexual behavior. A number of sexually transmitted infections. So safe sex, use of condoms, avoiding multiple sex partners. This will prevent a horde of sexually transmitted disease, including the HPV virus, which is being promoted. The vaccine against it is promoted. Vaccine will be piecemeal solution, because you may get a HPV vaccine, but you may get HIV, you may get syphilis, you may get gonorrhea, you may get a host of other in hepatitis B, hepatitis C. You may have a vaccine for hepatitis B, you may have a vaccine for HPV virus, but there is no vaccine for hepatitis C that is also sexually transmitted. So you have to use your contact with the patient advising. Suppose you get a patient with a sexually transmitted disease, syphilis or gonorrhea, you treat the patient. Then you advise on safe sex. You can say that these are treatable, syphilis is treatable, gonorrhea, but there are other which are not treatable. Maybe hepatitis C, which don't have a vaccine also, or HIV, which again do not have a vaccine. And so overall, safe sex will prevent unwanted pregnancy, then a host of sexually transmitted diseases. So this is depending on the individual patient. The patient comes with a problem, that patient is more receptive when the patient comes to the doctor. So that is the time when health promotion advice can be delivered. So could it have been prevented? Then same, you have to go back, reverse engineering, identify the specific risk factors, studying epidemiological risk factors. Say mother comes, child with diarrhea. You treat the diarrhea, discharge the patient. Again, she will come with diarrhea again after, and she may come with dehydration again. So you identify factors, the water hygiene, how they store the water, educate the mother, safe water for the child, safe food hygiene, and oral dehydration therapy to prevent in future. So that is the long-term solution. Otherwise, clinicians are very busy, but if they can take time out, they can reduce the caseload and improve the health. And depending on it, application to the individual patient, illustrative unwanted pregnancy, like mother comes, woman comes with an unwanted pregnancy. So you have to explore what can be the causes, what is the risk factor. Maybe many causes, like lack of awareness of contraception. Then some women may have a different incorrect knowledge of contraception, say rhythm method or some temperature, or which are not very reliable. So you have to find out in the individual case what have been the precipitating factor, and then you have to properly educate, or the woman may not be having access to contraceptives or contraceptive failure. So once you identify, taking the history, taking the uh, this can help in future unwanted pregnancies. Another thing, how much can be prevented? So the major four determinants, this is from population level data. You can educate the patient on this. Smoking is the biggest risk factor across the board for poor health, including mortality. Smoking contributes 11.2% to overall poor health, mortality, as well as morbidity, followed by alcohol. And now poor diet is catching up ahead of alcohol. You see, poor diet is 7.5%. Basically, ultra processed food, high sugar, high salt. A cup of caffeinated coffee may be having 45 spoons of sugar concentrates, and of course, sedentary lifestyle. So, smoking, poor diet, alcohol, and sedentary lifestyle. So, this advice can be given across the board. One can have a counselor. Identify these and other risk factors such as hypertension, serum cholesterol, etc., can help the clinician to focus consultation on preventive behaviors and the cause of some high risk factors such as high salt intake. Many people may not be aware of the salt content or sugar content of the packaged foods or ultra processed. They may be just that I'm not taking table salt at home, or in my cooking I am using less than 5 gram, 10 gram. But they should be made aware that see the small print label on the back and see the salt content, very high salt content or sugar content. And there is a Many people are trying to bring in a legislation where there is a front of package labeling of the sugar, salt, and saturated fat content. So unless that is in place, even if that is in place, the patient should be educated on this to see the. At present, it is at the back in small print. So they should read the small print when they calculate. They may be health conscious, but they may not be aware because this is put at the back in small print. So these are simple things, but these matter. Evidence base for preventive medicine. And nowadays, patients are quite aware now. They search the net, they search the AI, they come well informed. So doctors have to be on their toes and they have to talk the language of evidence-based medicine to build up the doctor-patient relationship. Evidence of the cause of the disease, evidence of efficacy of intervention. First is the cause, what caused the disease, so that future it can be prevented or the family member. And what are the interventions available? Different interventions may have different outcomes, or different interventions may have different risk also. All that have to be summarized for an individual case and discussed with the patient, giving the patient full choice. That is informed consent. And inferring causation is very complex because most of the, particularly the chronic diseases, non-communicable diseases, they have got multiple causes. Some act more in a particular case, some act less in a particular case. So again, as I said earlier, that your evidence is collected from the population and that evidence is applied to the individual patient. So that is clinical epidemiology. RCTs are available or not. You can do a Cochrane search, which compiles all the RCTs and makes a summary conclusion. And evidence-based medicine is the use of latest evidence in management of individual patient in consultation with the patient. That is the way forward for each case. And another thing is that sometimes there is a lack of, I mean, or there is a communication gap. Sometimes the doctors and laypersons and media also do not understand different terms. So I'll try to just list the common terms and common misunderstanding. Probability is the chance of an event. Say so many cases in the literature, 100 cases, what is the percentage of 5-year survival? Say certain cancer. So it is easy to understand. Or probability that 5% will survive for 5 years on this particular. Absolute risk is the absolute number of cases which occurs in the population. Say every year, there are, for every 1 lakh women, there are 10 cases of, say, cervical cancer, or 14 cases. So every year there are 14 cases. That is the new cases, incidence rate. For every 1 lakh women, there are 14 new cervical cancer. That is the incidence. That is the absolute risk. Relative risk is a comparison of two risks. Say a person is having a smoking habit and compared with a non-smoker. So you follow large number of people are followed to calculate that relative risk. So you find that in smokers, the lung cancer incidence is 10 times more than non-smokers. So that becomes the relative risk. So the smokers are 10 times more likely. But again, if there are no, in a particular community, there are no smokers, say religious community like Sikh community. So among that community, even if the risk is 10 times more, if it is, the risk factor is not prevalent. So population attributable. Every cancer is not always due to smoking. There are many smokers who do not get lung cancer, and there are many who get lung cancer even if they are not smokers. So there is no all or none law in most of the chronic disease. It is a risk factor. So attributable risk is an important concept in this. How much of the cancer cases can be attributable to smoking? So that is, or any risk factor for that matter. So attributable risk is the excess due to a factor. Incidence in exposed minus incidence in unexposed. The excess. There may be cases in those who do not have the risk factor. As I said, they are non-smokers who do not get it. So, but the higher the attributable risk, you can say the stronger the, yeah, burden by that particular risk factor. The larger the burden by that risk factor. So, because what happens is the patient may be having some preconceptions. Like my grandfather used to smoke like a chimney, he lived up to 90 years. So, you have to convey that some people may be smokers but do not get cancer, and vice versa also. But overall, in the population level, you are 10 times more likely to get. So, attributable risk is an important concept because sometimes you have to combine the absolute risk. Absolute risk may be very less, and attributable risk may be very less. But sometimes the relative risk may be very high. So, if you use the wrong measure in communication, you can create panic. I'll just give an example. How miscommunication can occur if you use the wrong measure. This is from a real case study. In 1995, UK Committee on Safety of Drug issued an urgent letter advising doctors increased risk of venous thrombosis for third compared to second generation oral pills. So official letter came that relative risk was used of 2. That means the third generation oral pill doubled the risk of getting clots, venous thromboembolism. Wide press publicity, and then the media hype takes over. And thousands stopped the oral pills, giving risk to many unwanted, giving rise to many unwanted pregnancies. So same thing, if you must have seen happen during the pandemic, the media raises the very lethal disease, very deadly disease. Whereas if you see the absolute risk would be, say, 0.1% or less than 1% mortality. But so this is a case study. What was the, as I said, one has to see the attributable risk in this instead of the relative risk. So this is the communication which occurred. Absolute risk on third generation pill was 3 per 10,000 person years. 3. Absolute risk on second generation was 1.5. So the absolute risk was very less, 3 per 10,000 and 1.5 per 10,000. But when you calculate the relative risk, 3 divided by 1.5, it becomes 2. So it is taken out of context that it doubles your risk. So people think it doubles means double risk ho gaya. But if you see the attributable risk, there's just a 3 minus 1.5 per 10,000 person years. Only increment in risk is, actual increment in risk is only 1.5 per 10,000. So this is a simple arithmetic. I had deliberately avoided complex statistics, but you should try to understand this simple attributable risk and relative risk. Whenever a marketing strategy is there to promote a drug or a vaccine, they always go for relative risk because ये double, triple ये अच्छा लगता है, 80%, 90%. But when you see the attributable risk, actual कितना होता mortality, जैसे एक्चुअल कितना होता तो और इससे कितना फर्क होता if the absolute risk is very rare, 10,000 में एक या दो, so you are almost a negligible risk from 1 to 1.5 increase. So many new drugs are vaccine and promoted on basis of, while attributable risk are only marginal benefit which may have no clinical relevance. Say mortality from cervical cancer as on today is say 10 per lakh, but 10, and if there's a vaccine you don't know 20 years back usko 10 से वो 7 कर लेगा या 5 कर लेगा. अब we don't know कितना efficacy है अभी क्योंकि HPV के भी कई strains है. तो actually from 10 per lakh your ये has come from 5. But if you take the relatives, they were so double. So there are many ways in which this statistics, wrong statistics may give a wrong impression. So to conclude, clinicians should take time to discuss the cause of these individual cases. This should explore the evidence and do their homework, and what is available in the medical literature, and how. And this is across all specialties. Now, these are the main issues. And now, since the most of clinicians are practicing uh, particular specialties, so they have time to do the research, evidence based in their own field, and talk with the individual patient. And in simple words, where possible, quantification of risk can help a balanced judgment on management of individual patient, taking the patient perspective into consideration. So I have tried to somehow make it as simple so that this can be communicated with the patient level. So these are some of the references. There is a very good handbook, Oxford Handbook of Epidemiology for Clinicians, because now more and more patients are becoming aware, and even they are looking up the evidence base. So this is, and there another book by Geoffrey Rose. He was a famous cardiologist, and he wrote a very good book, a very thin volume on strategy of preventive medicine. And he was the one who devised the cardiovascular risk factor surveys in the community questionnaire for that. I think I have finished. I can stop sharing. So that's all. If there are any questions, I can take.
Yes, doctor, thank you so much for your wonderful and deep presentation for our audience. So, during your topic, sir, we got some questions from our audience as well. So, can I go ahead and can I ask?
Yeah, please.
So, sir, the first question from our audience is, sir, like, how can doctors counsel the patient who are not willing to change their lifestyle despite knowing the risks?
The patient is always right, like customer is always right. So that's of course a difficulty. First is the patient, to win the patient's trust. First, there may be certain cultural gaps also. So one has to have a frank, heart-to-heart talk with the patients. What are the patient's worries? And then other is to counsel together with the family members, spouse or children, depending on. And of course, I agree, particularly those who are very strongly addicted to alcohol and very strongly addicted to tobacco. They may be very difficult. It's not easy to change behavior. So then there may be psychological counseling may be required, de-addiction centers, and other is using the family members who can. And it may not come in one sitting also. One should be have patience. How much trust you have to win the patient's confidence. One should not ridicule the patients. One should not be judgmental. If you are judgmental, they go on the defensive. Patient goes on the defensive. One should be non-judgmental. One should. That is the way. I mean, of course, there are some cases which may, but by and large, if you are non-judgmental, if you just say, "Why do you have this bad habit?" So that conveys a judgment. So why you have the habit of smoking? That is better rather than bad habit. बुरी आदतें हैं आपकी, तो वो जैसे ही वर्ड आप बुरी में जाओगे तो वो डिफेंसिव में चला जाएगा पेशेंट. So you have to just be very, very empathetic and not be judgmental.
So our second question is based on that only, sir. Like as you truly said regarding the trust in communication. So the next question will be like, sir, how important is empathy and trust in communication, and how young doctor can develop this type of the skills during their practicing time?
Empathy is most important. Actually, patient come for empathy.
Yes.
If you get the empathy, best way is non-verbal, listening to the patient. Because doctors are becoming so busy, they don't have time to listen. And another, I was reading somewhere that people are worried about AI. AI will replace doctors. In fact, AI will give you more time to doctors to talk to the patient. As on today, doctors are busy seeing the computer screen, entering the digital record and all that. So they are not having eye contact. So when the AI comes, you don't have to do all this mundane tasks will be taken over by the AI, and doctors will get more time for eye contact and listening to the patient. And that is the way to gain the empathy. So look forward to that, young doctors, because they will be working in an environment of AI. So they should know which impersonal task, record keeping and recording the case notes and all can be given to the AI. And the interpersonal interactions, they can devote more to listening to the patient, talking to the patient, and being non-judgmental. Being non-judgmental, and also you have to be also fit yourself. If a doctor, if I am obese, I cannot counsel an obese patient. So I have seen most doctors are also, because of the sedentary lifestyle, if a doctor is a heavy smoker, he cannot counsel. So all those, we have to set an example. It's
Yes, sir. Thank you. And the next question, what we received, doctor, in your clinical experience, what are the most common mistakes doctor makes while discussing prognosis, complication, or preventive measure with patients?
yeah, this is a very important, particularly the patient has a poor prognosis, how to break bad news. I think that is what the question is about.
Yes.
Or how to, I mean, that requires a lot of skill. And because if you avoid telling the prognosis, if the prognosis, there is a lot of hostility toward doctors. So that be there when there is a call. Doctors should go and attend the patient, talk to the family members. If not to the patient, at least gradually the family members can be told about the uh, uncertain prognosis, poor prognosis. So communication is again communication with the family members, empathy, and of course it's a art which can be learned by experience, by being patient, by giving time, counseling. So
So that's the question what we received from our audience, and you almost answer everything in detail. So let's conclude the session, sir. On behalf of entire Docplexus team and from our audience, we really thanks Dr. Amitav Banerjee for sharing your valuable insights and deep practical experience on very important and relevant topic, risk communication and promoting health. Your session, sir, has truly helped bridge the gap between technology and everyday clinical practice. And we also thanks to all our participants for joining us today, for your active engagement throughout the session. And we hope you found this discussion very informative and clinically relevant. So on behalf of Docplexus, sir, we look forward for many more collaborations and many more sessions with you, sir. Thank you
thank
so
you,
much.
Sifa. It's a pleasure. Thank you. Thank you. I'm switching off. Yeah.